Hi, this video is on depression and major depression disorder by Shannon Bandera, Jillian Oliveira, and Amanda Racine. Major depressive disorder typically involves 2 or more weeks of a sad mood or lack of interest in life activities with at least 4 other symptoms of depression. These symptoms can include anhedonia, changes in weight, sleep, energy, concentration, decision-making, self-esteem, and goals. Major depressive disorder is twice as common in women than in men. It is 1.5 to 3 times greater incidence in the first-degree relatives than in the general population. Incidence of depression decreases with age in women and increases with age in men. DSM-5 diagnostic criteria for major depressive disorder includes the following. 5 or more of the following symptoms during the same 2-week period and represent a change from previous functioning. At least one of the symptoms is either A, a depressed mood, or B, loss of interest or pleasure. Other symptoms include diminished interest or pleasure in almost all activities of life, significant weight loss when not dieting or weight gain, or increase in appetite, insomnia or hypersomnia, psychomotor agitation or retardation, fatigue or loss of energy, feelings of worthlessness and guilt, impaired concentration, and recurrent thoughts of death or suicidal ideations. The symptoms cause clinically significant distress or impairment in social and occupational or other important areas of functioning. The occurrence of major depressive episode is not better explained by schizoaffective disorder, schizophrenia, or schizophreniform disorders, or any other delusional disorders, or any manic episodes or hypomanic episodes in the patient's past. Why does depression occur? Researchers believe that the levels of neurotransmitters norepinephrine and serotonin are decreased in depression. Depression may result if too few neurotransmitters are released.
With over 350 million people affected by depression worldwide, it's no doubt an incredibly real and serious issue. But what exactly is going on inside of a depressed person? Is there a biological basis for these intense feelings of sadness? In the past, depression was often described as simply a chemical imbalance in the brain. Specifically, scientists believed that a lack of the neurotransmitter serotonin was to blame, which is often referred to as the feel-good chemical. However, the only real evidence for this was that when some depressed people were prescribed drugs which increased serotonin levels, it helped alleviate their symptoms. But while chemicals most certainly are involved, this view doesn't really capture just how complex depression is. In recent years, scientists began to notice that the brain cell growth and connections may actually play a larger role. When we look at the brain of a depressed person, studies show that the hippocampus tends to be much smaller than average. Other areas of the brain are also physically affected, but this region in particular controls memory and emotion. And the longer a person has been depressed, the smaller the hippocampus becomes. The cells and networks literally deteriorate. It turns out that stress may actually be a main trigger in the decrease of new neurons in this area of the brain. In fact, studies have shown that when this region of the brain is regenerated and new neurons are stimulated, mood improves. Interestingly, many modern drugs, including those which affect serotonin levels, have an indirect effect on the growth of brain cells. This is likely why serotonin-based drugs seem to help some patients, but not for the reasons we once thought. Instead, they promote the release of other chemicals which ultimately stimulate neurogenesis or the growth of new neurons. Knowing this, some scientists now believe focus should be on drugs which directly affect neurogenesis. But while your neurons and chemicals may be the direct influencers, many genetic factors have been discovered as well. One particular study found that a variation in the serotonin transporter gene leaves individuals more vulnerable to depression. Every individual has 2 copies of the gene, one from each parent, and this gene can either be short or long. After tracking 800 young adults over 5 years, the study revealed that 33% of individuals with one short version became depressed after stressful life events, and people with 2 short genes fared even worse. On the other hand, those with 2 long genes were much less likely to become depressed with similar life stress. Many other genes have been identified which increase the likelihood of depression too, and it makes sense when you consider that depression and bipolar disorder both run in families. Studies of identical twins show that if one has bipolar disorder, the other has a 60 60 to 80% chance of developing it too. So while the true cause or causes of depression have yet to be pinned down precisely, and trust us, there's a huge list of other variables that studies suggest may come into play, it's important to remember that depression is a disease with a biological basis, along with psychological and social implications. It's not simply a weakness that somebody should get over, or even something that we have a say in. And just like heart disease or cancer, shedding light onto the subject is of the utmost importance in order to bring funding and proper research. But is depression only a human phenomenon? We look into the question, do dogs get depressed, in our latest ASAP Thought video and discover the many studies done to understand depression among other species, including your pets at home. You can click the link in the description for that video. You can also check out the book Animal Madness by Laurel Braitman, which touches on the subject. In fact, you can get it for free from our friends at Audible by going to audible.com/ASAP. Audible is the leading provider of audiobooks with over 150,000 downloadable titles across all types of literature. You can download this audiobook or another of your choice for free at audible.com/ASAP. And with a subscription, you get one free book a month. Special thanks to Audible for making these videos possible. If you think you're suffering from depression, we've included some resources and more information in the description. And subscribe for more weekly science videos.
Untreated episodes of depression can last from a few weeks to months or even years, though most episodes clear in about 6 months. Approximately 20% of the population will develop a chronic form of depression. Depressive episodes can vary from mild to severe. The nursing assessment. You're going to take the history of the problem, any behavioral changes, when they started, and the duration. The general appearance and motor behavior, mood and affect, thought, process, and content. Also going to assess their sensorium and intellectual processes, judgment and insight, self-concept, roles and relationships, physiological and self-care considerations, and use the depression rating scales. Most of this assessment is done on your MSE. Here's just a list of the symptoms of depression.
Some nursing diagnoses for major depressive disorder include risk for suicide, imbalanced nutrition, less than body requirements, anxiety, ineffective coping, hopelessness, ineffective role performance, self-care deficit, chronic low self-esteem, disturbed sleep pattern, and impaired social interaction. Some expected outcomes for major depressive disorder include the client will not injure himself or herself, the client will independently carry out ADLs, the client will establish a balance of rest, sleep, activity, the client will establish a balance of adequate nutrition, hydration, and elimination, the client will evaluate self-attributes realistically, the client will socialize with staff, peers, and family friends, the client will return to occupation or school activities, the client will comply with antidepressant regimen, the client will verbalize symptoms of recurrence, and these all depend on the client. Nursing interventions include providing safety for client and others, institute suicide precautions if indicated, promoting a therapeutic relationship by spending non-demanding time with the client, promoting ADLs and physical care, only assisting as necessary, establish adequate nutrition and hydration, promote sleep and rest, engage the client in activities, encourage the client to verbalize and describe emotions, work with the client to manage medications and side effects, and provide client and family teaching. And this is just a picture of some suicide precautions. So you want to secure the room, have windows locked, break-proof glass and mirrors, plastic flatware. You don't want any cords for phone extension, equipment, curtains, belts, matches or cigarettes, sharps or razors present. For the patient care, you want a frequent observation, possibly one-to-one, staff communication, develop therapeutic relationship, written behavior contract, restraints as ordered, and medications as ordered. Some client-family education include teach about illness and depression, identify early signs of relapse, discuss the importance of support groups and assist in locating resources, teach the client and family about the benefits of therapy and follow-up appointments, encourage participation in support groups, teach the actions, side effects, and special instructions regarding medications, and discuss methods to manage side effects of medications. Treatment includes antidepressants, so you have the SSRIs, you have the MAOIs, there are atypical antidepressants and cyclic antidepressants. The choice of which antidepressant to use is based on the client's symptom, age, and physical health needs, drugs that have or have not worked in the past or that have worked for a blood relative with depression, and other medications that the client is taking. The goal of treatment is to increase the efficiency of available neurotransmitters and the absorption by postsynaptic receptors has decreased. So for the SSRIs, some examples are Prozac, Zoloft, Paxil, the newest category of antidepressants. They're effective for most clients and safer for the use in older adults. Their side effects include sedating, anticholinergic, cardiovascular effects. For the MAOIs, you have Marplan, Nardil, and Parnate. They're used infrequently because of potential fatal side effects and interactions with numerous drugs, and the side effects include hypertensive crisis.
Atypical antidepressants. These include Effexor, Cymbalta, and Wellbutrin. They're used when the client has an inadequate response to or side effects from SSRIs. It increases the action of certain benzos and H2 blockers. Cyclic antidepressants. This includes Elavil. These are the oldest antidepressants. They relieve symptoms of hopelessness, helplessness, anhedonia, inappropriate guilt, suicidal ideation, and daily mood variations. You should use cautiously in glaucoma, BPH, urinary retention or obstruction, DM, hyperthyroidism, CV disease, renal impairment, and respiratory disorders. They're contradicted in severe impairment of liver function and MIs. Hypertensive crisis. This is a life-threatening condition that can result when clients taking MAOIs ingest tyramine-containing foods and fluids or other meds. Tyramine-containing foods include mature aged cheeses or dishes made with cheese, aged meats, Italian broad beans, banana peels, overripe fruit, and avocado, all tap beers and microbrewery beers. Sauerkraut, soy sauce, or soybean condiments, yogurt, sour cream, peanuts, brewer's yeast, and MSG. Signs and symptoms of hypertensive crisis include occipital headache, hypertension, nausea, vomiting, chills, sweating, restlessness, nuchal rigidity, dilated pupils, fever, and motor agitation. These signs and symptoms can lead to hyperpyrexia, cerebral hemorrhage, and death. MAOI-tyramine interaction produces symptoms within 20 to 60 minutes after ingestion. The treatment is transient antihypertensive agents. Serotonin syndrome. This occurs when there is an inadequate washout period between taking MAOIs and SSRIs, or when MAOIs are combined with meperidine. Signs and symptoms of the serotonin syndrome include a change in mental status, neuromuscular excitement, and autonomic abnormalities. Other treatments for depression include electroconvulsive therapy, or ECT. This is an outpatient procedure that treats clients who do not respond to antidepressants or those who experience intolerable side effects at therapeutic doses. ECT is safe for pregnant women, and clients who are actively suicidal may be given an ECT if there is concern for their safety while waiting weeks for the full effects of the antidepressant meds. ECT involves application of electrodes to the head of the client to deliver electrical impulses to the brain, causing seizures. Shock stimulates the brain chemistry to correct the chemical imbalance of depression. Clients usually receive a series of 6 to 15 treatments scheduled twice a week. A minimum of 6 treatments are needed to see sustained improvement in depressive symptoms. A maximum benefit is achieved in 12 to 15 treatments. Nursing considerations include NPO after midnight, removing fingernail polish, voiding before the procedure, short-acting anesthetic, muscle relaxant, and during the procedure, you want to monitor the EEG, use oxygen therapy, and an ambu bag. After the procedure, you want to check vital signs, gag reflex, and provide food, treat headaches, and give antidepressant therapy to prevent relapse. A combination of psychotherapy and meds is considered the most effective treatment for depressive disorders. There is no one specific type of therapy that is better for the treatment of depression. Goals include symptom remission, psychosocial restoration, prevention of relapse or reoccurrence, and reduced secondary consequences. Therapies include interpersonal therapy, which focuses on difficulties in relationships such as grief, role disputes, and role transitions. Behavior therapy, which seeks to increase the frequency of the client's positively reinforcing interactions with the environment and to decrease negative interactions. Cognitive therapy, which focuses on the person, thinks about the self, others, and the future, and interprets his or her experiences. Other therapies include transcranial magnetic stimulation, magnetic seizure therapy, deep brain stimulation, and vagal nerve stimulation. This concludes our project on depression. We hope you enjoyed it.